Now, another issue, going back down here, is, okay, are antidepressants addicting? I've seen this other misconception naman na, I have seen pharmacists endorse this, local pharmacists, and it's quite alarming. Like, what are we teaching in schools? Okay, so, are antidepressants addicting? First of all, what is addiction? What is dependence? What is withdrawal? Are these all the same? Are they different? There might be some variations if you are using US versus UK nomenclature. But at the end of the day, I'm taking a cue from the British Association of Psychopharmacology, where we did the substance use training module. This is a pharmacology video series, so we're going to use pharmacology definitions. When we talk about dependence, we are referring to a physiologic dependence. That means a person is dependent, they cannot stop taking the drug because when they stop taking it abruptly, the brain receptors have, something going on with the brain receptors due to chronic administration. And what will happen is, when you stop abruptly, the person will experience withdrawal, which is a very painful, distressing set of signs and symptoms. Very distressing, and it'll depend per drug. And so because of this fear of withdrawal, they have to continue taking the drug. So it's a physiologic thing. They need to take it or else they will experience withdrawal. This is different from addiction. Addiction being a psychological craving wherein the drug is taken for its euphoric effects rather than to prevent withdrawal. And in the absence of the drug, even if you see something that reminds you, everything reminds me of, ganon, but apply it to drugs, you see a neutral stimulus and you already start to crave for the drug. So there is anticipatory craving, and then it's mainly for the rewarding feeling that you take the drug. That's addiction. Can a drug be both addicting and dependence-inducing? Yes. But are antidepressants both? No. Antidepressants are not addicting. We talked about the mechanism of action. Did I mention anywhere in that mechanism that antidepressants make you happy? No. Antidepressants are not magic happy pills. They are absolutely not. They can improve passive stress tolerance. They can improve the brain's capacity for learning. Sure, to deal with circumstances, but you still need to put in work to get to a better place, right? They are not addicting. They do not cause euphoria or cravings or none of that. But can they cause withdrawal if you have been taking them for a long time and you suddenly stop? Yes, they can. And the withdrawals, generally for serotonin related, ito yung pinaka-common set of signs and symptoms. This is for serotonin related withdrawal kasi there are changes in the serotonin receptor profile with chronic blockade of serotonin reuptake. So you get these. Although some of these might be difficult to differentiate from signs of depression, perhaps. So the effective ones, irritability, sadness. So usually, colloquially, we call antidepressant withdrawal brain zaps. Brain zaps because that's one of the very distinctive signs and symptoms for antidepressant withdrawal. As in, it's like kinokuryente yung brain. Like literally electrocution of the brain. That's the feeling. Some might even liken it to, it's like when you do a print screen but on your phone. Some people may liken it to that sensation. And then you see things like electric shock sensations, pins and needles. Like your fingertips are being pricked with needles. So something like that. Those are the ones distinct for serotonin-related withdrawal. And the picture will vary even more if you throw in other receptors, like for example, with antidepressants that are also H1 receptor antagonists, antihistamines. What happens? So when you have a chronically blocked H1 receptor and then suddenly you remove it abruptly. So let me use my hands to demonstrate this. Yan. So let's say at the beginning you have like one histamine receptor. And then you have antidepressant, but it also happens to be antihistaminergic. Okay, naka-block. It's blocked. Over time, your body's like, wait, why isn't the H1 receptor working? So the body thinks, okay, we need, as a homeostatic response, we need more H1 receptors because the H1 receptor we have isn't working. So it starts upregulating. Yan. So now the H1 receptors are upregulated. And as you experience tolerance, perhaps you might, whether it through be changes in dose or eventually the rest of the antidepressant diffuses to the other receptors. Okay, so now you have the upregulated H1 receptors. They are all blocked now. Okay. But then suddenly one day, you're like, whether due to the pandemic, you weren't able to go out and buy your meds or ran out of money, etc. Stop suddenly. Yeah. So now you have from one, now you have 5 histamine receptors that are unblocked. What is left in your body to bind to all of these unblocked H1 receptors that have been upregulated? The only thing left in your body that will bind to this is histamine itself. And histamine is not an antagonist, it is an agonist. What will histamine do on the H1 receptors? It will promote wakefulness in the brain. There you go. And that will lead to rebound insomnia. So usually, you will get the opposite effect. So withdrawal related to sudden removal of antihistamines after long-term administration, you get rebound insomnia. Kasi diba, antihistamines cause sedation, and then abrupt withdrawal, rebound insomnia naman. Same thing for anticholinergic drugs, say paroxetine. So you give paroxetine for a long time, suddenly you remove it. So you have upregulated muscarinic M1 acetylcholine receptors. So what will be left to bind to them? Acetylcholine. Rebound cholinergic. So again, it's important to understand the pharmacology of each individual drug so that when it comes to withdrawal, you don't have to memorize the withdrawal syndromes one by one. You can rationalize them based on the drug's pharmacology, right? It saves time on the memorization. It really does, okay? And while there is a wide spectrum of SSRI withdrawal, it's very important to differentiate relapse from withdrawal. While there may be overlap with, say, the affective, sleep-related, because these may mimic signs of depression, signs and symptoms of depression, take note of the somatic signs and symptoms that are not normally experienced in depression. Like, again, the brain zaps, pins and needles, will not normally see these in depression, right? So, very important to take note of those because traditionally, clinical trials have not paid attention to these traditionally. And so in this case, we have to apply some of our own clinical judgment so that we don't mistake na, ay, baka nagkakaroon ng ganitong mga signs and symptoms yung pasyente is nag-relapse, so kailangan ibalik yung antidepressant long term. Pero yun pala, kailangan lang pala i-taper, right? So this could make a difference between unnecessary continued antidepressant treatment and na pwede na palang itanggalin, kailangan lang i-taper. Conservative assumption that you can use, if a drug messes with monoamine neurotransmitters in the brain, just assume it can cause withdrawal, okay? Even for drugs you don't normally associate with withdrawal, like gabapentinoids, I'll just assume they cause withdrawal. And there have been cases that they have caused withdrawal because those things can affect monoamine neurotransmitters too. Antidepressants affect serotonin, so I'll assume they cause withdrawal. Yeah, and they do. They've been documented to cause withdrawal talaga. Okay, so very important, tapering. I won't discuss these graphs anymore. You can refer to Horowitz and Taylor for the detailed discussion on the rationale behind the hyperbolic tapering regimens in the monthly prescribing guidelines. Now, how long should these be taken? Generally speaking, based on relapse prevention studies, 6 to 12 months is a safe duration. Why 6 to 12 months? Because based on these observational studies, they can, in clinical trials, they can actually reduce the risk of symptoms returning, relapse, by up to 2/3, by up to 65%. Which is great, actually. For anxiety disorders, it might be a bit longer, maybe 12 months or a bit more. Yeah. But generally, that's more or less a safe duration to reduce the risk of relapse. But if a person has been having multiple episodes or maraming relapse, you might want to extend that to about 2 years or so.